completed his residency and fellowship in residency in ophthalmology and vitreoretina fellowship at the University of Toronto, and he then went on to receive advanced training in pediatric vitreoretinal surgery at the University of Southern California. He has also completed a master's degree in clinical epidemiology at the Harvard School of Public Health. He is our vice chair of clinical research, and he has also been the recipient of numerous teaching awards. He continues to be very active in clinical research and has a keen interest in randomized trials for retinal detachment repair, as well as prospective studies investigating the use of ocular fluid biomarkers to predict the severity and treatment response for common vitreoretinal conditions. Welcome, Dr. Muni.
Thank you, John, and thank you all for being here today. I wanted to first start by introducing my panelists. So we have Dr. Peter Curtis, who's the Chief of Ophthalmology at Sunnybrook Health Sciences Center and a vitreoretinal surgeon in Toronto, and Professor of Ophthalmology, and also Dr. Ken Ng, his partner at Sunnybrook, also Assistant Professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto. And I thank you guys for taking time out to panel this discussion. I also have three fellows here who are going to present cases, and so we're going to get right into it. The first case will be presented by Dr. Verena Juncal, who recently finished her clinical and research fellowships in vitreoretinal diseases at St. Michael's Hospital. She will present our first case.
Okay, can you see my screen?
Yep, we can see your screen. It's perfect.
All right. Well, thank you, Dr. Muni. So I'll present today a case of a 12-year-old female with an acute onset central scotoma in the right eye for the past 3 days. Her past ocular medical histories were unremarkable. On admission, she was 20/20 in both eyes. Intraocular pressures and pupils were normal. Slit lamp exam was also normal. There were no cells in the anterior chamber. On her fundus of the right eye, we could appreciate some venous engorgement and tortuosity. There were these retinal hemorrhages along the infratemporal arcades, in the small one in the supratemporal. And notice this retinal widening in the macula, actually extending somewhat outside the macula as well. And if I zoom into the posterior pole, you can actually appreciate this retinal widening surrounding mainly the venules. The left eye, her fundus was normal. This is the OCT of the right eye, showing this bent-like sections of hyperreflectivity at the level of the inner nuclear layer. And her left eye was normal. Fluorescent angiogram of the right eye showed a mild delay in the arterial venous transit time. But other than these blocked hypofluorescent areas from the hemorrhages, the FA was essentially normal. No areas of capillary dropout or anything suggesting vasculitis, and her left eye was normal. Now, keep in mind that the FA is a great diagnostic tool in retina, but what we're mainly seeing here is a superficial capillary plexus of the retina. And here we need to go in a little bit further into the deep capillary plexus. So we performed an OCTA, and if we look into the right and left eyes, we can actually see that there are reduced flow signals in the right eye, especially this superior and perifoveal area in the right eye. And the unfast OCT, also segmented to the deep capillary plexus, provides us with we can actually see these hyper-reflective areas. And if I give you this vascular mapping and seeing the venules, you can actually appreciate that it's a mainly a perivenular involvement in a fern-like pattern with periarterial sparing. So what is this? It's a retinal vascular occlusion, but not a simple one. It's a paracentral acute middle maculopathy, or simply PAM. Now, in order to understand well PAM, you need to know your retinal microcirculation and understand that arteries will come through from the central retinal artery, forming the superficial capillary plexus and supply the superficial retinal layers. They will also dig into the inner plexiform and internuclear layers forming the intermediate and deep capillary plexus. Um, Now, there is also some oxygen diffusion coming from the choroid and mainly supplying the outer retinal layers, but some oxygen will still reach the internuclear layer as well. So the internuclear layer ends up being a watershed zone here. And why paracentral? The parafovea is actually the thickest area in the macula. So there's less oxygen diffusion to the internuclear layer in this region, despite being an area of very high metabolic demand. So the internuclear layer, particularly at the parafoveal area, ends up being a greater risk for an ischemic insult. So PAM is a vascular insult leading to an ischemic cascade at the level of the deep and intermediate capillary plexus. And usually it starts closer to the perivenular pole in the scapulary bed because it's where the oxygen levels are reduced. So we end up with this kind of picture that our patient had, this perivenular fern-like pattern, and it may stop as it is and stop progressing, and this will give us a better visual prognosis, or it can actually progress laterally and diffusely involve the internuclear layer, giving us this globular pattern in the en-face OCT, which will be associated with a worse scotoma. Patient may complain of worse, meaning visual loss as well. And it may go even further and progress anteriorly and involve the superficial capillary plexus, giving us this very familiar picture of a retinal artery occlusion, which of course has a worse visual prognosis. And PAM may present itself in healthy patients without other retinal diseases or associated with various retinal vascular conditions like RAOs, RVOs, diabetic retinopathies, or even systemic conditions like hypovolemia, migraine. So in light of this, going back to our patient, we performed a very thorough workup, which came all back normal. We went also back to the patient and reassured that her review of systems was normal. She really denied any use of medications, and there was no recent history of dehydration. But there was one positive finding. She had a history of hepatitis B vaccine 4 weeks prior to the onset of symptoms. Well, this could have been just a coincidence, given that PAM has been reported in healthy individuals without any underlying condition. But we can't just simply ignore it, given that there have been a series of uncommon reports of ocular conditions and vascular conditions occurring after vaccines, including 5 cases of RVO after hepatitis B vaccine. And there's not really a reason established for this kind of association, but some theories involving the role of deposition of immune complexes with complement activation, antigenic cross reactions, but nothing very solid. So we observed our patient, we monitored her closely. This is her a month later. Her fundus really looked as if nothing ever happened. And here the OCTs 1 month and 3 months later. And we can notice the gradual improvement of the hyperreflective areas. We end up with an internuclear attenuation because of the areas that had an ischemic infarct. Her vision remains stable at 20/20, and she informs that her paracentral scotoma has mostly disappeared, which is actually the most common visual outcome in these types of cases. Thank you.
Thank you, Verena. So if there's questions from the audience, what we'll do is we'll have the audience simply put them into the chat, and I can bring them up to the speakers at appropriate times. But for now, we'll go on to the next topic.
Great. I'd now like to introduce Dr. David Takim, who will present the next case. David Takim is a second-year vitreoretinal fellow at St. Michael's Hospital.
So Verena, maybe I'll ask you to stop sharing your screen.
I'm trying to.
Okay, I can do that for you. There you go.
Okay.
And that will allow David to share his screen. There you go.
Good afternoon, everyone. So I'm going to be sharing a very interesting case that we did with Dr. Muni last year, removal of an intraocular nematode. So let me just, there you go. Okay, so this is a case of a 35-year-old man of Bangladeshi origin who presented with a 6-week history of left eye pain, blurriness, photophobia, and floaters. He had moved to Canada 9 years prior and had most recently visited Bangladesh 3 years ago. He had no significant past medical history, not take medications. His review of systems was non-contributory, and he had no exposure to animals or raw meat, and he felt pretty well systemically. So on initial examination, his uncorrected visual acuity was 20/25 in the right eye, 20/40 left eye. His intraocular pressures were pretty much normal. On slit lamp examination, he's phakic in both eyes. He had a little bit of cell in his left eye, dilated fundus examination. I'll show you a picture in just a second. The right eye was normal, but the left eye, he had some vitritis and a non-mobile nematode that you can see here on the picture. We didn't see any chorioretinal lesions, and we also have an IVFA that I don't have here, but it was non-contributory as well. So I have the surgery video that I'm going to show. I don't think the audio is going to work through Zoom, so I'm going to try to narrate it as it goes along. Let me see. So this patient went under 23 gauge paraspinal vitrectomy with chandelier illumination. The nematode was clearly identified in the vitreous cavity, as you can see here. So here we're just examining the worm with bimanual technique, just taking a look. We weren't sure if it was still alive or not. We're just trying to uncurl it, trying to see what the best way to remove it intact was. So here you can see actually that the head curls a little bit. We thought it might still be alive at this point. Always hard to tell. So we did a limited core vitrectomy here to release the nematode surrounding vitreous. And then we use an MVR blade to create a 20 gauge sclerotomy. We use an angiocath that was actually connected to the viscous fluid extractor. So here we are using the bimanual technique. We aspirate the worm that's been partially freed from the vitreous into the angiocath. And then we switch back to vitrectomy to remove the remaining vitreous strands. And then we remove the worm intact. So here it is in the syringe. Then we close up the eye. And so at this point, we took the sample and we gave it to the resident. It was Amrit in this case. He brought it down himself to the microbiology lab and he watched them transfer it into another container, made sure that they go, and that's always very, very important in these cases. However, despite our best efforts, about a week later, we got a call from microbiology saying that they couldn't find a specimen. So, you know, that's a little bit unfortunate. So we don't have the punchline to this case, but this is a very interesting case of how to remove a intraocular nematode from the eye intact. And we recently published this in AJO case reports. Actually, just got accepted and will be in the press. Thank you.
Yeah, thank you. You know, for the vitreoretinal surgeons in the audience, you know, with the Constellation machine, you know that sometimes you get that reflux of bubbles or material. And so what we were trying to do, instead of not just eat it up and have worm particles then kind of go back into the vitreous cavity, we're just trying to remove it intact in one piece. That was, unfortunately, we couldn't speciate the organism, although I believe Toxicara, right, was the was the most likely diagnosis.
From looking at the pictures, microbiology thought it might be that, but you know, we didn't have the final answer.
Excellent. Well, thank you, David. And at this point, we'll go on to our third case, which is Natalia Figueiredo, who's our current research fellow at St. Michael's Hospital and who will be starting a clinical fellowship next year in Calgary. So Natalia, please proceed with your case.
Okay. Let me share screen. All right. Thanks, Dr. Muni. Thanks, Ali, for this video. I have no disclosures. This is a case about a 30-year-old male who was referred with a large intraocular foreign body in his right eye 5 days ago when working with metal. He had unremarkable medical and ocular history. The visual acuity in the right eye was 20/30, and the intraocular pressure was 13. There was a small peripheral corneal laceration seal, a mild AC embryectomy, and a clear lens. The retinoscopy in the right eye, we can see a metal intraocular foreign body, intranasal, optic nerve, and macula. This is the video. I'm not sure if you're gonna hear the music. It was a nice Game of Thrones song. Okay, 23 gauge PPV was performed. We can see a large intraocular foreign body infranasal to macula. Triamcinolone was injected to assist with posterior vitreous detachment, which can be very challenging in young patients. Further core and vitrectomy was performed. The foreign body was firmly fixed in the sclera and required manipulation to be released. And blade was used for sclerotomy, and the foreign body forceps was used for extraction. Replacing the foreign body in its original cavity allowed for regrasping it in a more favorable orientation for extraction without additional trauma to the retina or lens. The foreign body was then externalized and measured. It had 15 millimeters in diameter, in length, sorry, and 1.5 in diameter. And the laser barricade was applied to the area surrounding the chorioretinal scar, a defect, and there fluid exchange was performed. All wounds were closed and prophylactic intravitreal antibiotics were injected. 1 week post-op, the acuity was 20/70 and intraocular pressure was 13. There was a mild posterior subcapsular cataract. The macula was attached, the retina flat, and we could see the laser scars. And then 3 weeks post-op, the went down to counting fingers due to the advanced cataract. The macula was still attached, the retina was flat, and at this point, the patient was referred for cataract extraction. So some points to bring up in this case was that usually in foreign bodies, they are removed right away. But in this case, the eye was quiet and there was no inflammation really. So if we could delay and do an elective, also if any other approach as chandelier. Thank you.
Ken and Peter, I was just wondering if you had any thoughts about that. I mean, usually we do IOFBs right away as soon as they come in, generally. This patient had a 5-day history. The eye was quiet, but there was, you saw that pigmentary reaction around the foreign body. And so I've been burned. I remember one time when I waited till the next morning to do one, and where there was this severe vasculitis then like 6 hours later. But how would you guys approach this case?
I think in general, I would try to take these to the OR as soon as possible. I mean, you never know when endophthalmitis might start to begin. It was a really nice video, a nice result. I mean, the 2 videos are actually were very instructive. The one thing I might have done a little bit differently, in the Nematode video, you inserted a chandelier to start, and that helped your visualization greatly. And you're able to use a bimanual technique. You know, with the IOFB, the illumination was just with a light pipe, and it may have limited you a little bit in terms of visualizing the IOFB and its course within the vitreous cavity. But you also don't have a second hand to hold on to the end of the IOFB as well, because you can sometimes hold on to it and then grasp the IOFB with the original forceps and then reposition it to help it find a better course out of the eye through your enlarged sclerotomy. So that's maybe the only thing I would have done differently during the surgery. Timing wise, to have that much chorioretinal reaction after 5 days seems a little bit. I guess if there's no other history of trauma, I mean, it had to have happened at the 5-day mark, and it's hard to fault you for going in, less than 12 hours later. But I wouldn't wait too long, I don't think.
Yeah, they're great cases. I agree. I mean, the issue is endophthalmitis. I mean, these cases are at such high risk for endophthalmitis, and when they get endophthalmitis, the outcomes are universally terrible. So, yeah, I mean, I treat all intraocular foreign body. I mean, I shouldn't say that. I mean, there's some that end up coming to you years later, but for those that are still relatively acute or subacute, I think I would treat them all as emergencies. But I mean, it's amazing. So did he wait 5 days to come in to get looked at? Is that the?
Yes, yeah. He was referred by an anterior segment surgeon, a complex anterior segment surgeon, who I guess got the referral to remove it, but he referred it to me and told me that there was a 5-day history. I agree that the RPE change there is a little bit suspicious, though, for a longer history.
Yeah, I mean, these foreign bodies are toxic, and you see the whole spectrum change. I think it's definitely the right thing to do to leap in and do these cases early. I mean, and your nematode case as well. Like, do we have some sense from his symptoms how long that had been sitting around for?
Oh, it was a while, a long time. Yeah,
Years, yeah.
he got referred from Thunder Bay and had inflammation for a while, and then got referred to an ophthalmologist who then referred him to me. But that was a longer uveitis.
Wow, great business.
So Verena, Natalia, and David, thank you for your cases. There is a question here for David or Rajeev about the intraocular nematode and what systemic treatment was given.
David, do you want to take that?
Sure. Yeah, he was, because we couldn't figure out what kind of nematode was in his eye. He was seen by ID, of course, with anti-helminth. I don't have the exact agent on, but it was treated systemically for a month afterwards. They also worked him up systemically, checking out all sorts of serologies for all sorts of parasites that I'm not familiar with, and nothing else was found, unfortunately. So a whole extensive work was negative. So they just did him empirically. He hasn't had any other manifestations of infectious disease on that end.
Great. All right. So I think I'll go into my talk now. And today I'm going to be talking about a paradigm shift in retinal detachment repair. And I'd like to thank the organizing committee for the Doves Rounds. This is a great initiative that we have during these times for us to all stay connected while social distancing. So I'll just get started here. So I'd like to start by showing you this picture of a patient who had a rhegmatogenous retinal detachment repair 3 months prior. And this patient had a vitrectomy. And when we look in, we see that the retina is nicely attached, that there's good laser treatment around the peripheral retina there, and things look relatively good. And so as the physician, usually our response is that, everything looks great, you've done really well, the retina is fully attached, and, now just give it time and let's see how you do. But unfortunately, despite that, a lot of times this is how the patient feels about the outcome of their detachment surgery. Regardless of how good of a job we did, the patient can have other symptoms such as distortion and anisoconia, and this can be severely debilitating to patients and make them feel that they did not have a successful outcome despite our best efforts to inform them about that. And so when we look at this patient in more detail, if we look at the outcomes, we see that the visual acuity was 20/25, but the MV and MH, that refers to the distortion score, with 0 being no distortion and 2 being maximum. And he did have a fair bit of vertical and horizontal distortion, and also an anisoconia score of 24, which goes from 1 to 30. So there was significant anisoconia, and it's surprising that this patient wasn't happy with their visual outcome. So this is another patient who had a retinal detachment, and this is a common presentation where we see a superior detachment, superior break, and some lattice degeneration inferiorly. And everyone knows that in Toronto, we do a lot of pneumatic retinopexies, and this is something that has become quite popular in the city, and we do it a lot. And there's a lot of centers across North America and in Europe where a lot of them are done. But generally speaking, it's not a commonly performed procedure for retinal detachment repair, and we'll get into that. But 2 hours after the you can see some fish eggs here, but the retina was significantly better. And by the next day, we have a fully attached retina. And by 2 weeks later, the bubble's gone, the tear is lasered, and the retina is attached. And I remember, the residents who are with us today, you see these patients in and out through our clinics, and I was surprised, even as a junior resident, how these patients could come in, and with a relatively simple, elegant procedure, you could do something very meaningful, even as a junior resident, being obviously supervised by a fellow, that you could be involved in something like putting a retina back in place. And I think that was a great thrill that I had as a resident, and something that kind of pushed me forward in my career and being kind of intrigued by this procedure. But we have to step back a little bit and go back to the history of retinal detachment repair. And I'm going to start in 1949, when Custodes was the first to describe a scleral buccal procedure that did not require drainage. And I think that's probably where it started in terms of procedures such as pneumatic retinopexy, where we realized that if you just close the retinal break, that you'd achieve retinal reattachment without having to drain the fluid, either internally or externally. And from there, retinal detachment surgery has evolved. There was significant modifications to the way we do scleral buckle, which dominated from the 40s probably up to the 80s. And then vitrectomy surgery was introduced by Machamer, and there were several refinements to that technique. And in there, pneumatic retinopexy in the 70s and 80s was described by Dominguez in Spain and Hilton and Grizzard in the United States. And they and basically there was this period of time where scleral buckling and then pneumatics were being done, and then vitrectomy was becoming popular. And the first trial was the pneumatic retinopexy trial that compared vitrectomy compared pneumatic retinopexy to scleral buckle, and demonstrated visual outcomes favorable for pneumatic retinopexy. But basically what happened after that was that minimally invasive vitrectomy surgery kind of took over, and it became the kind of efficient, effective way to repair retinal detachment, as well as all kinds of other vitreoretinal procedures. We had all these amazing novel instruments and techniques, and it became kind of the cool way to fix a retinal detachment, and basically now dominates how we treat these patients, despite the fact that there isn't a single randomized controlled trial demonstrating that vitrectomy is better from a functional perspective compared to scleral or pneumatic retinopexy. And so it's really has a lot to do with the advantages of doing the procedure from a technical perspective, and also industry being heavily involved. Vitrectomy surgery has really taken over. And if you look at these practice trend surveys, you see that for phakic retinal detachments in the United States, vitrectomy is the most common procedure, whereas internationally there's still a lot of buckles that are being done. And for pseudophakic detachments, vitrectomy by far is the most commonly used procedure internationally. So we had these three different techniques, and we know that with pneumatic retinopexy in our hands, that we see patients who have very good outcomes. When you have a patient who's had a buckle or a vitrectomy, that eye is never the same. There's always something wrong in terms of the patient, from the patient's perspective. And I recall seeing lots of pneumatics where it was as if they only had a tear that was lasered and nothing had happened. And there's nothing like an untouched eye, and that's what we. And that's one of the main reasons why we favor retinopexy in Toronto here. And so at the University of Toronto, we performed this randomized control that compared pneumatic retinopexy to vitrectomy, with the goal not of looking at anatomical attachment rates as the primary outcome, but functional outcomes. And so what we found was that pneumatic retinopexy was superior at every time point, including the 1-year final endpoint. And what was interesting was that we all know that vitrectomy causes cataracts, but we were very aggressive in moving cataracts as they occurred in the trial. And so 65% of the phakic patients in the vitrectomy arm had cataract surgery during the trial, so that by the 1-year endpoint, we would have from untreated cataracts, and we could focus really on the retinal detachment outcomes. We also looked at visual function scores, and it was significantly better for pneumatic with the NEI VFQ-20 at 3 months and 6 months, but no significant difference at 1 year. Now, to get into the controversy around retinal detachment repair, if you talk to people in various parts of the world, they say that they want to do the procedure has the greatest chance of success the first time around. They want to do something where they're not going to have to take the patient back. And that's a valid concern. And so when we looked at the primary anatomical reattachment rate, we found that the difference was about 12 to 13%. So it was a 93% primary reattachment rate with vitrectomy versus a 81% success rate with pneumatic in terms of a single operation success. But if we look into that in more detail, that line of reasoning to support vitrectomy, we see that the difference is about 12% between the procedures, which leads to a number needed to treat of 0.3. So in other words, if you're advocating for less surgery or less procedures on patients, a vitrectomy first approach would lead you to do vitrectomy surgery on all 8 patients to save 1 patient from requiring an additional procedure. Not to mention that you would have to do cataract surgery on all of these patients in 1 or both eyes potentially. Now, moving on to other outcomes in the trial, we also found that the pivot trial, which the most interesting things was that vertical metamorphopsia, that patient I showed you on the first couple slides, this patient had significant vertical metamorphopsia that was impacting vision. And in the trial, we wanted to look not only at visual acuity, but distortion. And we found that patients who had vitrectomy had significantly greater risk of vertical metamorphopsia compared to pneumatic retinopexy. And this was the first time that any 2 procedures were compared in a randomized fashion where we were looking at outcomes other than visual acuity. And not only was the severity distortion worse, but the proportion of patients who had distortion was also significantly worse with vitrectomy. And this to us was a light bulb basically went off at that time when we saw these results, because we realized that perhaps the mechanisms of action in these 2 procedures are different and lead to a different quality of retinal reattachment. And so the first thing we did was look at the OCT results, and lo and behold, we did find that there was a greater proportion of patients in the vitrectomy group that had disruption of the retinal layers. And you can see disruption of the interdigitation zone and the ellipsoid zone. And this was the type of thing that was more prevalent in the vitrectomy group. So what's happening? Why are we getting different procedures having different rates of distortion and anatomical outcomes at a microstructural level? And so I want to go back to that original case that I showed you with the 20/25 vision and compare it to a pneumatic case, which ended up having 20/20 vision. But the patients, if you look at the pictures, you'll see that the retinas are both attached, that there's good laser retinopexy, and both should have had a successful outcome. But let's look at it more carefully. If you look at this patient who had the vitrectomy surgery, if we look at the fundus autofluorescence imaging, we see this phenomenon called retinal vessel printing. And what this is a hyper autofluorescent line. It indicates the location of the retinal blood vessel before the retinal detachment and and we can compare it to the location of the retinal vessel after the retinal detachment and see what the shift has been. And this was described previously, but perhaps not recognized as a cause as much of these functional outcomes that we were experiencing with our patients. Furthermore, when patients have these findings, retinal vessel printings, we also see that there's a greater risk of disruption of the interdigitation zone where the retina attaches to the RPE. And that makes sense. When the retina has been shifted to a different location, of course, the interdigitation between the photoreceptors and the RPE would be abnormal. Let's compare that to our case of pneumatic retinitis, who had no vertical or horizontal distortion and no anisoconia. Mind you, this is not every patient, but we do see this more often in pneumatic retinitis. And look at the fundus autofluorescence, you see it's pristine. We do not see any signs of retinal vessel printing or retinal shift. And so when we saw this in our cases, it led us to ask the question, could this be occurring more so in vitrectomy compared to pneumatic retinopexy related to the mechanism of action of how the retina reattaches? And it also led to the point that anatomical reattachment does not equal success. So based on the current research, I don't believe that if a patient comes in and you see that the retina is attached, that's enough to say that they've really had a truly successful anatomic outcome. I think that you have to look at the OCT and you have to look at the autofluorescence imaging in order to make that determination. Now mind you, some of these poor anatomical outcomes with patient may be some of our control, but I think we're finding more over time that it's not out of our control and that we can do things to minimize it. This is another great example of a patient who has retinal vessel printing, and you see that the inferior arcade has been shifted down at least 0.2, 0.3 millimeters. And you can imagine where there's millions of photoreceptors, this could have a tremendous impact on a patient's functional outcomes. So the historical focus on primary retinal reattachment is really something of the past. And a new paradigm will involve paying more attention to functional outcomes. Anatomical reattachment is really the bottom of the pyramid in terms of success. We then want to look at the macro and microstructural integrity. By macrostructural, I'm referring to autofluorescence and is the retina back in place where it was before? And microstructural from the OCT perspective, are the outer retinal lines intact to the greatest extent possible? And when we tend to this, we find ways to improve our functional outcomes for patients. Now, as I mentioned, this unintentional displacement of the retina after vitrectomy surgery is nothing new. This was described in 2010 by Shiragami. But what is new is that this was never compared between different techniques. It was always done within vitrectomy and modifications of vitrectomy to try to minimize it. And despite various efforts, there has never been a way to eliminate this occurring with vitrectomy surgery. And most series, even to this day with modern techniques, we're still finding rates of about 40 to 50% retinal displacement. This has just come out yesterday in ophthalmology. This was also performed at the University of Toronto, is what we call the integrity study, where we compared retinal displacement in a multi-center retrospective study comparing pneumatic retinopexy to pars plana vitrectomy. The purpose of the study was to compare retinal displacement after vitrectomy versus pneumatic using fundus autofluorescence, and to also look at all the functional outcomes and the OCT. This was a multi-center study, as I mentioned, between Hamilton Regional Eye Institute, the Newcastle Eye Center in the UK, and St. Michael's Hospital in Toronto. So basically, patients would come in for their 3-month follow-up after retinal detachment repair. They'd have an autofluorescence and OCT, and they had a number of functional outcomes that were done as part of their routine care. If we look at the baseline features, which is very important, we see that there's no significant difference in any of the significant baseline characteristics. And this is because the centers that we chose were specifically chosen for the methods that they use. So in Newcastle and Hamilton, they don't do many pneumatics at all. And in St. do pneumatics on almost all cases. And so what we wanted to do is have all these centers recruiting patients so that the same patient with the same type of morphological detachment would get one procedure at one center and a different procedure at a different center. And so this allowed us to have a balanced cohort. And these were the results. The rate of displacement in the pneumatic group was 7% compared to 44.4% in the vitrectomy group, and this was highly statistically significant. We then to do a subgroup analysis. Is it possible that all the vitrectomies were getting larger, had larger detachments, and all the pneumatics were smaller detachments? So we also looked at only small detachments and only large detachments separately, and also found the same statistically significant difference, always favoring pneumatic retinopexy. We also looked at how we do the procedure. We looked at drainage through the break versus a posterior retinotomy. We looked at different types of tamponade used, and none of those factors displacement in this study. That comes back to why we think this is happening, which I'm going to explain very shortly. Now we talked about the functional outcomes, and we found that patients with displacement had significantly worse visual acuity. They had more morphopsia, more abnormalities on the OCT, in the interdigitation zone. So in conclusion, for the study, we found high integrity retinal reattachment, or a retinal where the retina remains as close as possible to its original location, was much more common with pneumatic retinopexy compared to vitrectomy. And low integrity retinal reattachment, or LIRA, is much more common with vitrectomy surgery. Now, let's talk about the mechanism of why this is occurring. So we've been able to collaborate with the Department of Chemical Engineering at the University of Toronto, and there's a chemical engineer who's basically helping us to create models, computer models that we can use to try to simulate the action of the various factors that lead to this. And what it comes down to is that when you inject a bubble into a fluid-filled eye, you basically have a buoyant force of the bubble. And this buoyant force depends on the height of the bubble. So the larger the bubble you have, the more the buoyant force applied to the retina. And you think of this force as exerting a pressure on the retina. And so if you have a smaller bubble, you're also applying this pressure. Think of it as a hand being applied to the retina with a certain pressure in a smaller area versus the whole retina with a larger gas bubble. And there's this thing called the bond number, which is, beyond my, it's a very complex thing, but basically refers to the deformability of the molecules. And for example, silicone oil has a very low bond number, whereas gas has a very high bond number. And the higher the bond number, the higher the pressure that is applied to the retina. So with gas, you're applying greater pressure to the retina compared to something like silicone oil. Now I'm going to show you some animations that we were able to create with a medical illustrator who we work with. So in this case here, you're going to see this is a patient who had a vitrectomy. Now you see this residual fluid. As the patient's head position changes after surgery, we see that the fluid usually migrates inferiorly, and the current of fluid under the retina is leading to the photoreceptors and the retina being stretched, and that leads to this retinal phenomenon. So basically, it's the flow of fluid under the retina which is causing a stretch of the retina, and that leads to the photoreceptors misaligning to the RPE. And here is another view of the same thing. And basically here in this cross-sectional view, you'll see that the fluid is moving from posterior to anterior at the end of surgery as the patient changes their head position. And as this fluid is flowing, you'll see that the retina gets stretched and leads to this, this displacement that we're seeing. And if to convince yourself, take a very thin sheet like a bed sheet and pass your hand under it like a wave of fluid. And you'll see that there'll be striations in the sheet, and it'll cause a stretching of the retina. And this is what we believe is the displacement of the retina. Now let's compare that to pneumatic retinopexy. So here we inject a gas bubble into the eye, And then we position the patient usually face down initially. This is called the steamroller maneuver to reduce the overall amount of fluid that has to be reabsorbed by the RPE pump. But mind you, the majority of, or that final attachment of the photoreceptors with the RPE occurs naturally by the RPE pump reabsorbing the fluid. And so as the RPE pump reabsorbs the fluid, we can see that the photoreceptors are able to interdigitate more nicely to their original location. And it makes sense. Something that's occurring naturally by the RPE pump is much more likely to reapproximate the retina to where it was rather than a forceful internal drainage that we typically do with vitrectomy surgery. We all talk about the wallpaper analogy. We want to put the wallpaper back on. And many surgeons will say that I want to do the procedure that's going to put the retina back on in its position with one operation. But we can't ignore the fact that we also want to do a good job. We don't want it to just be attached. We want to have a high integrity attachment. We don't want folds such as this or stretching of the retina, but we want the retina attached as close as possible to its original location. I want to show you one case of a patient where we tried something differently to try to avoid retinal displacement, but where we didn't succeed, but where we learned a valuable lesson. We all know about perfluorocarbon liquid and how it can be used for various scenarios in retinal detachment repair, but there have been several reports of perfluorocarbon being used in retinal detachment repair as a short-term tamponade. And considering the theory that I just showed you about why we think we're getting retinal displacement, the thought occurred, what if we use perfluorocarbon liquid as a tamponade rather than gas, avoid the air fluid exchange altogether, and see if we can minimize this retinal displacement. So this was a patient, a 61-year-old male who had a failed pneumatic retinopexy with a total retinal detachment, and the patient had a vitrectomy with perfluorocarbon liquid. And here I'm going to show you, I want you to pay attention to how the fluid is being displaced. So here we see that there was shallow everywhere, but more bullous inferiorly and temporally. And as the perfluorocarbon liquid is being injected, I want you to pay attention to where the fluid is going. The fluid is moving infratemporally and also inferiorly here, and inferior. And what we decided to do in this case was to leave the perfluorocarbon liquid inside the eye and we lasered the break after the perfluorocarbon liquid is in. And we closed up the eye, we sutured the wounds and left that liquid in. And we then took a picture 7 days later, and lo and behold, that retinal displacement was still present. And the outer retina showed some disruption there, and the patient had poor vision. And if we look at the 1 month picture, that liquid was removed after a few days, about 7 days later. And if you look at 1 month photograph, we see that the retina is nicely attached. And like our first patient, they had a good visual acuity, but had subjective complaints of distortion with similar types of M-chart findings and some mild anisoconia. And if we look at 1 month, we have this picture, which is probably one of the nicest pictures of retinal displacement that I've ever seen, where you can see significant retinal displacement of, again, 0.3, 0.4 millimeters. And if you pay attention to the direction of displacement, you'll see that the retina has been displaced down and temporal. Same direction of fluid flow. So this helped confirm to us the mechanism of action, which is that the fluid flowing the direction what causing the displacement, and we want to minimize flow of fluid to minimize the risk of low integrity retinal reattachment. So if you look at this animation in this specific case, what we're seeing is the perfluorocarbon liquid causing a stretch of the retina related to a flow of fluid from the fluid escaping from these inferior breaks. The superior break was mostly attached to the previous pneumatic retinopexy around in that area. So most of the fluid was being drained infratemporally. Now, I just want to spend a moment for mainly for the retinal surgeons to tell you the difference between slippage and stretch. So we all talk about slippage during surgery and how to minimize that, but that's a very different concept than retinal stretch. And so in this animation, I'm just going to show you what slippage refers to. Slippage refers to the perfluorocarbon liquid being injected, and we eliminate fluid through the retinal break. And this is how we treat giant retinal tears, for example. And then as we do an air fluid exchange, after we've lasered the break, now you're going to some of that fluid that's anterior can migrate posteriorly. And so what I want you to pay attention to is the direction of flow. Fluid is moving from anterior to posterior, and that's leading to redundancy of the retina and a retinal fold and slippage. And this is very different than the retinal stretch, which I showed you, which is the opposite, the exact opposite, fluid moving from posterior to anterior and leading to a stretch. So you can see that with retinal detachment repair, you can get a redundancy, and you can get retinal folds and slippage or retinal displacement. And both of them are bad and can lead to poor functional outcomes. But recognizing the rationale and the mechanism of action of why this occurs in both cases can lead to improved functional outcomes. I just wanted to end on one note that despite all the advantages, how great we think pneumatic is, there's many forces that drive why we do vitrectomy in some cases for patient factors, access to OR, all types of reasons. And vitrectomy is obviously not going to go away. We're going to continue doing vitrectomy, and in many parts of the world, pneumatics will still never be done. So this has now shifted into how to minimize retinal displacement with vitrectomy and with other surgical techniques. So I just want to briefly mention that I have studies where a small number of buckles have been done, and it looks retinal displacement rate is very low with sclerobuckle. This makes sense based on our theory that if we allow the RPE pump to reabsorb the fluid, you can have better outcomes from a displacement perspective. And we have a larger prospective study looking at this as well. And what about the other factors in vitrectomy, such as vitreous substitutes, head positioning, and other intraoperative tools? We know pretty well that gas has a lot to do with it, and the pressure that gas and the force that gas applies to the retina. And we know that we get it much less with silicone oil because of the lower number with silicone oil and the fact that silicone oil applies less pressure to the retina. We also know that immediate face-down positioning with multiple trials now, including one that just came out a week ago in JAMA Ophthalmology by Cal, that shows that in randomized studies, if you do immediate face-down in the operating room, you will minimize retinal displacement. And if there's one that for your vitrectomy surgery, I would say is that immediate turnover onto face-down is better than having them sit up and then being wheeled to recovery where they, have a coffee and a cookie and then go face down, because in that interval, that 5 or 10 minute interval is what can cause the retinal shift. So what you want to do is leave them flat on the bed. If you want to wheel them out on their back, it's fine. But once they turn over it should be an immediate turnover to face down, recovery, or in the OR. What about perfluorocarbon liquid? There was one recent paper that showed that in a small range that might benefit of using perfluorocarbon liquid during surgery, but several methodological issues with this trial, which I don't have the time to get into, but I'm not sure I fully am convinced of these results. You'll see the p-value is 0.049, and I think we need data on this. So in conclusion, pneumatic retinopexy first line has acuity and metamorphopsia results with less morbidity. Pneumatic and other RPE-based procedures likely, like sclerobuckle as well, offer a greater chance of achieving this high retinal attachment. Anatomical success requires two things, not just an attached retina, also a high integrity attachment. And this concept of integrity will lead to modifications in our techniques and improved functional outcomes for patients. So I'd like to thank all of you for listening. And I wanted to turn it over to the panel to give us some comments. And I think, Amandeep, we have a number of other staff vitreoretinal surgeons that are joining us today. So I'd like to stop talking and get some of the other viewpoints here as well.
Sure. So I guess we'll open it up to Dr. Curtis and Dr. Ng first for their input.
Thanks, Amandeep. I mean, that was that body of work, that ongoing body of work that you're doing is truly outstanding. It's really, I think, changing the way we think about retinal detachments and retinal detachment repair. I had a couple questions. You found in the pivot trial that the vision was better in those that were treated with pneumatic compared to those that were treated with vitrectomy, and that seemed clear. And then there was a small number that that had higher primary reattachment rate with vitrectomy than pneumatic. And I know we have pivot extended that's going on. Hopefully the COVID business won't stop and follow up of those pivot extended patients. What's your mind? What's the break point? Like we expect in pivot extended that probably there'll be more failures both in vitrectomy and pneumatic. So how much higher primary reattachment rate do you need to justify, X number of letter of vision? Have you thought of, where the break point? I mean, obviously the break point will lie in different places for everybody. There are people that will look at the evidence and, pick out bits and pieces that justify what they like doing. But for you, and for patients in general, where's the break point for you?
Yeah, so I don't think it's a break point in terms of reattachment rate. Like I said, I at the bottom of the pyramid in terms of I want to see which one has the functional outcomes. Let's say hypothetically in pivot extended, which for everyone is going to be basically more complex detachments, which have a higher chance of pneumatic retinopexy. But even when you have a failed pneumatic, the majority of the time, or many times, the retina, the macula is reattached almost immediately in 4 or 5 hours. And so even if the procedure fails, you can have an attached or a macula with a detached periphery, and you can then go on to do vitrectomy surgery. So if someone told me that, there's a much greater chance, let's say in the extended cases, of requiring 2 procedures, but a much higher chance that I'm going to have a better functional outcome and less distortion and less vision, I mean, what would you choose? I think I would choose the procedure that was going to allow me to see better at the end of all that. I personally would not mind having a second procedure. But, obviously you have the perhaps the 87-year-old patient who can't position very well and doesn't want to for follow-ups and is not going to be very with positioning. So I think each physician, like always, will make a decision that's individualized for each patient. To me, functional outcomes will be the biggest factor. I mean, obviously, don't a failure rate of 30% or 40% because that will lead to all the patients getting vitrectomies anyway. So that the break point is if you're purely looking at a primary anatomical reattachment rate, I would like to see something in the 60s or 70s to make it all worthwhile. But at the end of the day, I'll be driven what functional outcomes are.
To follow that up, it's important to recognize that in patients that present macula off with poor vision, there's not a lot to lose, and so for a lot of those patients, whether you're going to take them to the OR or not, it's going to be something that's going to happen probably in the first few hours anyway. So you have time for a pneumatic. However, I think we have to exercise caution in those patients who can on. If it's a case where they may not be the best candidate for a pneumatic, to plow ahead with one can sometimes be a mistake, because there's nothing worse than starting with a patient who's MAC on 20/20. You inject a gas bubble in them and they come back a couple of days later, count fingers. Because in those cases, you've now given them a poor, both anatomic and functional. So I think those are the cases where the fellows know that with me, we have to be a little bit careful. Those are the patients where you really want to give some sober second thought sometimes to doing that.
Yeah, no, I mean, just the other, I was just trying to find the images, but someone sent me a patient who had macula on superior retinal detachment single break, and the patient ended up having a vitrectomy with perfluorocarbon and had at the end of the surgery said that there was no fluid through the fovea. And someone sent me the OCT. I'll try to find it. But basically, the patient had these changes on the OCT, and they were just outer retinal folds that involved both inferior and superior to the macula. And going along with our theory about why this is happening, what my hypothesis was that there was some anterior fluid that migrated posteriorly at the end of surgery. And then with the tamponade, with the gas bubble, all of that fluid was pushed through the fovea and led to these folds, the less than ideal outcome. So I agree with you, Ken, that yeah, like I think in the extended cases where it's not likely to work, you know, and I think we all have to make that judgment call. But I also don't think that, you know, we should, you know, assume that vitrectomy isn't without complications. I think that we've shown with this displacement work and with all the other potential things that can happen with vitrectomy that you can have bad outcomes that are unintentional with vitrectomy as well. And so, you know, it is a more invasive procedure. So I think you got to, like, I think, you know, I agree with you. You got to consider the specifics of that case. I mean, if there's a 6 o'clock break with a macula on retinal detachment and the chances of it working are 10%, yeah, for sure. But if it's, you know, a patient who has a break at 3 and 5 and macula on, is a good positioner, and is motivated, then it's worth a try. So I think that we have to individualize it.
And I think it's important. I mean, positioning is not, if we're talking about pneumatic versus vitrectomy, positioning is not negotiable. So we position patients who have had a vitrectomy as well. It's true they have a bigger gas bubble and positioning is less critical, but I mean, all patients have to position whether they have pneumatic or vitrectomy. I mean, I think that's important to keep in mind as well. I have another question. I think very rarely consider the progressive cataract as a morbidity in vitrectomy, but many of our colleagues don't. You know, many of our colleagues will take out a lens, even a lens that's mostly clear at the time of vitrectomy, and they don't really think about. We all know there's good treatment for cataracts, and you know, you might endear yourself to your cataract colleagues by accelerating the development of cataract. But I mean, I think it's not trivial to make patients aware of the fact that, you know, one surgery will beget another surgery. It's true that surgery's much simpler and almost always very successful, but I think that's something to consider as well.
Yeah, I mean, I think the cataract story, it's the problem. It causes, it confounds a lot of these trials because it's hard to tease out what's from the detachment. I mean, I think that you know, it's definitely a morbidity. I don't think that we can assume that just removing the cataract is simple and that there's nothing bad that can happen. Like, we know that a lot of patients will have anisometropia and cornea and will have to have the other cataract removed. You know, these patients are at higher risk of retinal detachment as it is, and so they will, you know, you're potentially putting their other eye at risk as well. So I think that, you know, it should be a consideration. But going back to the pivot trial, I think we were very aggressive in removing cataracts. And I remember Peter and I having discussions about that, and, you know, not being so aggressive with removing the cataracts because you want to replicate what happens in everyday life, which is where, you know, the patient ends up having to wait 6 months. In the end, we felt the general audience for this kind of paper would take that as a great limitation of the study. And so we ended up removing almost every significant cataract so we can really isolate the effect of from the retinal detachment repair.
Yeah, I think that would for sure.
As a cataract surgeon, I might just pipe in and say, you know, we have great treatment for cataract, but I do caution post-vitrectomy cataract as slightly higher risk than the average cataract patient without the support, as well as the potential of some zonulopathy or some compromise of the posterior capsule. These patients are slightly at higher risk for complications during cataract surgery, having been vitrectomized. Now, Rajeev, question for you, just for the general audience here. Maybe you can share with us the traditional indications for pneumatic, as well as maybe some of the extended indications for pneumatic retinopexy.
Yeah, so you know, the traditional we do pneumatic retinopexy on are those, it started out with the pneumatic retinopexy trial. So you have patients with a single break or multiple breaks within 1 clock hour in the superior 8 clock hours in detached retina with no other pathology in detached retina. That was the original criteria. And then in Pivot, we just expanded on that to make it a little bit more generalizable. So they could have any other pathology in attached retina. And by doing that, we greatly increased the number of patients who would be eligible to about 50% of patients that present. Extended criteria basically includes everything else, and that varies based on physician. I generally, for anything that's below 5 o'clock or 7 o'clock, I would tend not to do a pneumatic. For anything that has pathology above 5 and 7 o'clock, and as long as it's on one side in terms of inferior pathology, then I would try a pneumatic first. If they have multiple superior pathology, I'm also going to try it first. I think one thing to remember with pneumatic retinopexy, and a lot of people who do it, many of them will tell you this, that when the mistake is that when you have a pneumatic, that you sit on it for a long time and wait. So if it's a Thursday and your pneumatic has failed and you're not operating till the next Thursday, I think that's when you get some bad outcomes with PVR and other things. So I like to, when I have a failed pneumatic, I'd like to not wait for too long and try to get them in the OR very quickly. So the extended criteria are, I would say when you're starting out with, you stick to these criteria as 8% success rate. And when it's failing, it's also early on that you don't get discouraged. It's failing, you should move to vitrectomy. But also don't panic. Like on the first day after pneumatics, you always see displaced fluid inferiorly, so you need to give it a couple of days. But once it's clear that it's not working, delay the surgery.
Perfect, thank you. Out of interest, we are actually running a. We usually do this poll at the beginning of the round. On poll now, it's always nice to know where the audience is from. A significant international audience the last 2 weeks, so I'm going to launch a poll, and I'm hoping that most of the audience will participate and tell us where they're from. So I'll let that run for a few more. I think we've got about 60% response rate there. Okay, so I'll share the results with you guys. The audience, it looks like, is in Ontario, Canada, the US, Europe, as far away in Africa. So that's fantastic. And we've got a couple more questions in the chat here. Oh, there's some Caribbean folk here too. I'm sorry, I forgot to put that in the queue as an option. Now there is a question for the VR surgeons, indications for PFO as tamponade post-op. So I don't know who wants to tackle that.
Sure. Peter or Ken, one of you want to talk about that?
Yeah. I mean, the indications for me are never. I mean, we know that PFO is if you have sort of unlimited access to the OR and lots of OR time, I guess you can do it. Can't really fit for very long. It's pretty inflammatory and pretty toxic. I mean, there are other options for heavier than water tamponades like Denseron if you feel that's valuable. But
I think the question was just in general, use PFO even intra.
Yeah, I mean, there.
Same thing, never.
Yeah, I mean, I basically never use it, but I think you can justify it in a giant retinal tear, especially when the retina's folded over and taco on itself. I never say never, but I'm very close to never feel the need to use PFO.
There was one question about the positioning when you use PFO as a tamponade. Actually been randomized trials comparing gas to PFO, because the one advantage is that the patient can lie supine, and you can, if they can't face down position, the positioning is easier. By no means am I advocating this. This was a an attempt to minimize retinal displacement, and it clearly didn't work. So I don't think I would do it again for that reason. There have been a couple giant retinal tear cases where I've left it in for a week and then removed it. Generally, it's used intraoperatively. I like for giant retinal tears, I use it a lot, and also for complex stitches. I'm doing a retinectomy and PVR.
I would agree with that. I mean, I think the audience needs to recognize that PFO is not designed to be used post-operatively, with the exception of F6H8, which isn't very, it's probably the most inflammatory of all the compounds we have. So it's sort of a non-traditional approach, and I guess it's been best described in GRT cases where most people would take out the PFO in a week or two. So I use it never as post-operative tamponade, and only really to unfurl giant retinal tears during regular rhegmatogenous retinal detachment surgery.
We've got an interesting question here. Do you think that there's ever, or do you think there's any potential help for patients who had a good anatomical retinal reattachment, but that they have distortion or metamorphopsia due to retinal displacement? So is there a role for going back in and trying to address that?
You know, at one point I thought about, you know, if someone had very severe distortion and significant displacement, one possibility could be to go back in. I haven't had the guts to try this yet. But if someone had, you know, sometimes when you have a macular fold, we go in and we detach the retina and then we smoothen out the fold and then allow the retina to detach. So a thought occurred to me that in displacement cases, if someone had very symptomatic metamorphopsis thought to be related to that, then you could go in, redetach the retina with a 41 gauge cannula and allow the fluid to settle on its own. The problem is that most of those patients have good visual acuity. So even if they are complaining a lot about their functional outcome, it would be a very aggressive maneuver. And so I would wait until there's a patient who's really, really symptomatic, I think, to try that.
Yeah, I agree. I mean, the only way I could think of addressing it would be to redetach the retina. And we have, you know, in large part with your help, but from others as well, we figured out ways to try and minimize displacement. It would be hard to, I mean, so the converse of that is we can maximize displacement. We have to displace it in the right direction. So it's hard to control that displacement, I think. It would be pretty, I mean, chances are you would end up with certainly a no better outcome, but there's a significant risk of worse outcome, I would think.
So the one rationale for that kind of technique would be that you wouldn't necessarily have to put a gas tamponade in the eye. So you could detach the retinas in a way that there was no open break. Then theoretically the RP pump could, the patient could lie supine and you would avoid that fluid flow. I mean, we're talking experimental at this point, but the rationale would be to avoid any tamponade.
Well, the proof of concept of that would be when we try to displace submacular hemorrhage. You know, we use a 39 or 41 gauge translocation cannula, inject a subretinal TPA solution, but we put a tamponade agent in. I usually use air or maybe SF6. And so there's lots of stuff under the fovea at the end of the case. And then usually they come back at day one totally flat, hopefully with displacement of the fluid. Now, whether that would really make you better in the case after a, you know, rhegmatogenous retinal detachment, it's hard to direct the fluid in the right way, but you know, you can definitely have lots of fluid under the retina at the end of the case and still have it look pretty good shortly thereafter.
There's a question here. A good idea is when you have a